All right, so Module 9 is going to go over chapters 32 through 36. This is pretty much finishing up trauma for you guys. We're going to talk about spinal trauma, abdominal trauma, chest trauma, and all that good stuff. First and foremost, just make sure you guys are just familiar with the anatomy and physiology. You might have to review chapters 7 and 8 again, just so you understand all of the anatomy. But the chapters do go into a brief detail of each section that they're going to talk about. See, it's not letting me change the slide. Hold on. There you go. So chapter 2 is your spinal injuries and spinal motion restriction. Like I said, each chapter is going to go over the A&P. So spinal anatomy, remember you guys have two different types of nervous system. You have your central nervous system, which consists of your brain and your spinal cord. And then you have your peripheral nervous system, which is kind of like all of the nerves outside of the brain and spinal cord. So this is the nerves going down to your hands, your feet, all of that good stuff. Remember, you have your voluntary nervous system, which is muscles that we can control. Pretty much your peripheral nervous system. This is us being able to walk. We tell ourselves when to walk. We tell ourselves when to grab something. And then you have your autonomic nervous system. You know, we don't control when our heartbeat. I can't say stop beating and it just stops. And we don't really control, like, when we need to produce bile and urine and stuff like that, you know, and technically breathing is also an autonomic nervous system. Yes, you can hold your breath, but we don't actually think on a day-by-day, second-by-second basis of I need to inhale and exhale. When it comes to your spinal cord, just make sure you know that the spinal cord is your nerves going from your brain down into your body. Your spinal column is the actual bony promises that makes up your spine and your back. The spinal column, it consists of 5 different sections. Your cervical, which is your C1 through C7. Your thoracic, which is your T1 to T12. Lumbar, which is your lower portion of your back, is your you can say your L1 to L5. Your sacral is also 5 bones, and then at the very end, which we call it our tailbone, is your coccyx, which are your fused vertebrae. Remember that the cervical, any injury in that area, anything below the cervical injury can cause what we would consider paralysis on down. Remember, your phrenic nerve is in between your C3, C5. If that nerve is damaged, then you pretty much are no longer breathing. So a lot of times when we do see paralysis or, you know, someone's paralyzed on one side, like the left and not the right, or they're paralyzed waist down or all 4 extremities, arms and legs, it's normally due to some type of injury in the cervical region of the spinal column. So just pretty self-explanatory. Just remember those numbers. You have 7 cervical, 12 thoracic, 5 lumbar, 5 sacral, and 4 coccyx. And your tailbone is your fused vertebrae. All right, so injuries to the spinal cord. There are common mechanisms of the spinal injury are automobile crashes, falls, GSWs. These are like common injuries or mechanisms of injuries that you would suspect some type of spinal injury possibly has occurred, especially if the force is just that strong. There's different types of injuries that can occur with the spine. Uh, you have your compression, which is when the weight of the body is driven against the head. So just think of somebody who dived into a pool and they hit their head first on the bottom of the pool, or seeing with somebody falling off or something and like the roof and they're landing head first. Uh, that kind of compresses all of that force, compresses against your spinal cord, your spinal column, and can cause severe injury and possibly paralysis on down, because it's going to start from cervical and work its way down to spinal cord. Then you have your flexion. This is a severe forward movement of the head where the chin meets the chest. You can see that a lot in car crashes. Along with extension, which is severe backward movement of the head when the neck is hyperextended. And once again, this is something that you can also see with a car crash as well, being rear-ended, things like that. Then you have your rotation, which is a lateral movement of the head or spine beyond its normal rotation. So this is kind of like hyper rotating it past point of its normal resistance. You have your distraction. This is when the vertebrae and the spinal cord are stretched and pull apart. Commonly seen in hangings, you guys. It's just going to pretty much, just like it says, just pull apart from the rest of the spinal column. Penetrations this is trauma that has involved the cranial or spinal column. Penetrations could be your low velocity injuries like a stabbing, or your medium to high velocity injuries, a GSW from a Glock or AK-47, or even from a blast injury when you have an impaled object that has impaled either your spinal column or your cranium. One thing that possibly, if there is a complete injury to the spinal cord, you will possibly see what we call spinal shock. Signs and symptoms of spinal shock are loss of muscle tone, loss of sensation to light touch and pinch, and patient is unable to move. So this is when you go and you check your PMS. The patient is awake and alert to speak to you, and you're asking them, can you wiggle your toes, or can you feel me touching your toes, or anything like that. This patient will probably be saying that they don't feel you touching and they're unable to move anything, or they might think that they're moving their toes, but you're looking at their toes and nothing is moving. So you need to think that possibly this patient has done what we would call a complete spinal cord injury. The blood pressure normally is low. However, the difference between this shock and like your regular shock, like hypovolemic shock, is this patient doesn't present with that cold, clammy skin. They might be warm and dry, but like I said, they don't have that sensation of touch, motor, or pain at all in that muscle below the injury. And then we go into what we considered incomplete spinal cord injuries, you guys. So an incomplete spinal injury is pretty much when the entire cord has not been injured. There's 3 different types of injuries that affects the patient in different ways. They either would lose sensation to painful touch, or they lose sensation to light touch, stuff like that. Or they lose sensation to motor. And we're going to go and talk about each one. So first off, just to go over, it is important to just check patient's motor, sensation, pain sensation, and light touch. That's one of the reasons why we always check PMS. So the first one we're going to talk about, I don't know how to do the marking. We're going to talk about the central cord syndrome. and your incomplete spinal cord injuries? So this again is an incomplete spinal cord injury that has not completely gone through all the major tracks of your motor, touch, and pain. Um, so that means that the patient will still have some sensation to certain uh, motor tracks, but not everything. So a patient with a central cord syndrome will present with weakness or paralysis and loss of pain sensation to the upper extremities, while the lower extremities have good function. So this is someone who, they can feel you touching their legs, they can wiggle their toes for you and all that good stuff. However, when you ask them, can you feel them touching you, or they feel you touching their fingers or stuff like that, or can they raise their arms, they won't be able to do so because that central cord has damaged the motor pain and light touch sensation of the upper extremities. Okay, that's pretty much it for that one. The next one, you guys, is your anterior cord syndrome. Anterior cord, I just think about it, I see it as all below. This is due to injury of the sensory and motor tracts located in the anterior portion of the cord. However, the only one that's not affected is your light touch is not affected. So this patient can't feel pain stimulus on the site below the injury. So if it's in their cervical area, they won't be able to feel you stimulate pain stimuli on the arms and anything below. But however, they can still feel light touch. So you brushing your finger across their arm, stuff like that, they can still sense that sensation. But if you go to pinch them or just twist their finger to cause like a painful stimuli, they won't be able to have any sensation of that at all. The patient will also present of loss of motor function below the site of injury, so they also won't be able to move any extremity below that site of injury. So if it occurred in their cervical area, this patient pretty much will not be able to move any of their four extremities. So this thing, central cord, remember all of your weakness and paralysis, loss of pain sensation occurs to the upper um, extremities of the injury. Your anterior cord is everything below the injury, except the patient does not lose a sensation of light touch. They lose motor and pain only. Your Brown-Séquard syndrome, it only affects one half of your spinal cord, either the left or the right. We call it a hemisection injury, or you can just say Brown-Séquard syndrome. The patient will experience motion and sensory loss below the site of injury, and it's only going to be on the side of the cord that it was affected. So if it's on the right hand side, they pretty much won't have any uh, motion or any other sensation on the right hand side versus the left. They can still feel you touching them. They can still feel pain. They can still have motor sensation, all of that. All right. Is there any questions about the three incomplete spinal cord injuries? All right, so let's see. So once again, just remember your common mechanism of injuries that will cause you to be suspicious of a spinal cord injury, or things like motor vehicle crashes, for sure, motorcycle crashes, uh, falls, blunt trauma, penetration trauma to the head, neck, or torso, sporting injuries commonly seen in football, hangings, diving in or other water-related injuries, especially if that patient dove into a pool and landed head or hit head first at the bottom. And just suspect this in any unresponsive trauma patient that you might have if you're unsure of what injuries could have occurred before you got on scene. So you always want to just go ahead and just do your get on scene, take immediate immobilization of patient's head or spine, and keep that immobilization until you have either ruled out spinal cord injury or until you pretty much got them on the spine board with head blocks and stuff like that to where you still have them in a mobilization restriction. And just always check your PMS. If they had it when you got on scene and you got them on the spine board after, check it again, check it in the truck. This is something you should be checking every 5 minutes just to make sure that that sensation is still there and it has not gone away. Because if so, that means that some type of injury has occurred in the process of moving them from wherever you found them at to the spine board and cause further damage to the spinal column or spinal cord. So, long spine boards are no longer recommended for routine use in the case of spinal motion restriction. Um, we still do, however, use them for extrication movement, but in most cases should be removed from beneath patient once placed on the stretcher. Uh, long spine boards have been shown to cause tissue damage and increase movement due to patient discomfort. It is very uncomfortable for them, especially if they're going to be on a long, let's say, transport time to the hospital. On these bumpy roads we have in Louisiana for sure, just bumping and you have a hard board against your back can just make them very uncomfortable. And also just when you have your promity bonus promises like in your ankles and stuff like that, that against hard surface just tears down your skin, can cause what we would consider like a bed sore per se. So in most cases in today's society, we typically would use it to extricate the patient, but once we do get them on a stretcher, we are normally removing that spine board from underneath the patient. And a lot of times patients with some type of injury normally would keep themselves in a position of comfort uh, the entire time throughout route. So a lot of times it's just no longer needed. However, we still do use it in some cases. So this just talks about spinal motion restriction on the patient that is ambulatory. You advise them to look forward in a neutral position and you just apply the C-collar and have them sit on the stretcher and remind them to keep their head in a neutral position and remain still. Like I said, so this is probably someone that's only complaining of neck pain. They're not complaining of any type of back pain. You don't suspect um, any type of spinal cord injury or spinal column injury down the back. So you can just apply a C-collar and have them sit in a position of comfort on the stretcher. However, for your non-ambulatory patient, establish spinal motion restriction. So this is probably someone that is unresponsive. Place the C-collar, use the long spine board or a scoop stretcher to place the patient onto the stretcher, and then just remove the device and keep the patient as still as possible with the head in a neutral position. So now we're going to get into chapter 33, talk about some eye, face, and neck injuries. Let's see. There we go. So you guys just look over your skills at the end of each chapter. Talks about how to apply C collars and put patients on spine boards. So once again, it's important to know the anatomy and physiology of the human body. If you need to go back into chapter 7 and 8, going ahead and do so. Chapter 33 does talk about each body structure for the chapter, but they don't go into great detail. So the eye has a lot of, like, as you can see, has a lot of different anatomy parts of the eye that make up our eye. The sclera, you guys, is the tough outer portion. That's the white that you see whenever you're looking at someone else's eye. Then you have your cornea. It's the clear portion that covers over the pupil. Let me see, I don't do the little pen. So your cornea right here, it's that clear portion that's right over your pupil and iris. And then, of course, everybody knows when you're checking pupils, that's the black dot pretty much in the center of everybody's eyeball. That's the thing that constricts or dilates, with your fight or flight. They're either going to be dilated when you're running away from something or are frightened of something, or it has a stimulus of your sympathetic nervous system, or they're dilated, which is something that we also look for when we're trying to rule out if a patient has overdose on a narcotic or overdose on a benzo. There are pupils who are going to either be constricted or dilated. Also, just, when you cut the light on, your pupils normally go from being really big to a small black dot in the middle of your eye. So just something to keep in mind. We learn a lot just from looking at people's pupils. If one does constrict and dilate and the other one doesn't, it just stays the same. Might have to rule out some type of head injury, stuff like that. And then you have your lens, which just focuses the light onto your retina. So light will shine in into the eye, reflects, and then it just sends down to your brain through the nerves and copies that image to you. I need to get this to stop. All right, so next you have your facial bones. The skull altogether has like 22 bones. Your facial anatomy makes up about 14 of those bones. There's different type of fractures that can occur. You can have fractures in your eye socket area. You know, um, Remember, if you see what we call the raccoon eye, or looks like a black eye, you need to think of a basal skull fracture. Your mandible, which is the jawbone that does move, can be fractured from traumatic injury. Your maxilla, which is the fixated upper jaw, can be fractured. And your malar is just your cheekbone, your zygomatic bone. Just think of somebody getting hit in the face. Your cheekbones are kind of prominent; they stick out a little bit more than your other bones in your face. So a lot of times when someone is swinging a bat or something at you, your cheekbones are going to be the first point of impact and can pretty much fracture your cheek. And just think for car crashes, especially if someone's head went through the windshield, you might suspect some facial fractures. You're going to definitely see a lot of bleeding in the face because the face is very vascular, you guys. So just keep that in mind. Even like a small abrasion can just bleed, bleed, bleed. All right. So before we talk about the injuries, we're just going to talk about the anatomy. So just remember, in your neck area, you do have your carotid arteries that go from, pretty much brings blood from your heart up to your brain. And then you have your jugular vein that brings deoxygenated blood back from your brain to pretty much the heart, and then it's pumped, out pretty much through the lungs, and just does that whole perfusion gas exchange process all over again. So any injuries in this area, you need to have a high suspicion of, one of these arteries or veins could have possibly been nicked or damaged, depending on if the penetrating object or blunt force. You also have your trachea in this area that could be damaged from blunt force or penetrated object. So just keep that in mind. Very vascular area, and we're going to talk more about it as we get into the injuries. All right, so let's just go over. I got a couple of injuries to go over. So let's say you do have a foreign object in your eye. Like if it's dirt, sand, dust, and if it's in the conjunctive tibia. I'm sorry, you guys. Um, if you can remove it with what we would consider a flush, you want to make sure that you're using clean water and that you're flushing to where it drains not down into the other eye. Just have the patient turn their head to where it's pretty much draining down and just going down that same side of the face, because you don't want to bring, especially if it's a chemical, you don't want to bring it from your left eye to your right or from your right to your left. Chemical burns to the eye is a medical emergency, you guys. If you notice that the patient has possibly been burned in the eye from a chemical during your scene size up or your primary assessment, you need to start irrigating that eye immediately. We typically irrigate the eyes for at least 20 minutes or until we arrive to the hospital. Um, Impaled objects or an extruded eyeball, we do not remove, nor do we try to put the eyeball back into the socket. What you want to do is you want to encircle the eye and the impaled object with gauze and dressing, and don't apply pressure over the eye at all. So a lot of times, if you have like a little knife or pencil in someone's eye, you want to put like a cup over that infected eye and to stabilize that cup on that eye, and make sure you just wrap both the affected eye and the good eye as well, and transport those patients to the hospital immediately. Patient does have contact lenses, try to remove the contacts if you can. Like I said, don't apply any pressure over the eye. Uh, and just make sure that you still cover both the bad eye and the good eye. Uh, so let's say patient got hit in the mouth with a bat, and you found broken teeth all around the patient's house. You want to transport any tooth that you found in a cup of saline or wrapping gauze soaked in sterile saline. You never want to wrap the tooth in dry gauze, and you never want to handle the tooth by the root, because you can make the tooth non-reattachable. And you don't want to waste time on scene looking for a tooth. If you can't find it, you can't find it. That person is just going to be toothless. If you do have an impaled object in your patient's cheek, you guys, if it's not going all the way through the cheek and into um, the mouth, you want to just stabilize that object in place and transport the patient. However, if it is going through to where it's going into the cheek and coming out into the patient's mouth, and is at risk of obstructing the patient's airway, you want to attempt to remove that object from the patient. So you want to pull or push the object out of the cheek in the opposite direction it was inserted. So if it went from the cheek into the mouth, just pull try to pull it from the mouth and out. Or if it was from the mouth and came out through the cheek, just pull it from the cheek. You want to pack the dressing, dressing material between the patient's teeth and the wound, and once again, you want to just dress and bandage the outside area of the wound as well. Because remember, the face is very vascular, so it's gonna bleed pretty much until you get to the hospital. If you do have ear injuries, you remember we don't want to stick anything necessarily in the ear canal. You want to just place dressing over around the ear so that it can catch whatever blood is draining from the ear. And when it comes to neck injuries, you guys, keep in mind that air can enter a vein through the neck. So you always want to apply, it's kind of almost like treating a open chest wound. You want to apply an occlusive dressing. However, instead of taping that on 3 sides, you're going to tape it on 4 sides. And you can just apply regular gauze over that wound to, try to control any bleeding around the area. So neck injury or neck wound, occlusive dressing taped on all 4 sides with sterile dressing on top. All right, so we're going to get into the next chapter, chapter 34, and talk about some chest injuries. Once again, so we're going to go a little bit over the chest cavity once more. So, internally inside the chest, you have your trachea and your esophagus that goes further down, and your trachea branches off into your left and right lung, right? Right lung is a little larger than the left lung because you have this, what we call mediosternal notch area more on the left hand side because the heart kind of turns more to the left, and that area just is where the heart kind of like sits in, along with other organs, along with like the lung and some of your rib cage and stuff like that sits in the area. When it comes to the lung, you guys, pretty much each organ has a um, how to say, like a lining that goes over the organ itself, and it goes over the outside of the organ, and in between is normally like a little fluid in the area. So we're gonna go more into that with the lung. There we go. All right. So pleura. You have your visceral pleura, which anytime you see visceral, that means that it is attached to the organ itself. So this one is lining that is attached to the lung. And then your parietal pleura would be just attached pretty much to like the chest wall. Oh, I didn't do that. So parietal pleura is attached to your chest wall, and your visceral is actually attached to the lung. And in between that is what we call the pleural space or pleural cavity. This is just a little amount of fluid that just helps prevent with the friction as your lungs expand and deflate. When it comes to chest wall trauma, or like either caused from a blunt force or penetrating force, this pleural space is what we worry about because that can open up and just cause, especially if it's from an outside force, like a gunshot or stabbing, it can open up and just cause air to seep in and just cause pressure buildup in between the parietal space, giving that lung less room to expand fully and eventually causing it to collapse. All right. I'm sorry, you guys. All right, so I'm gonna go more in depth with open chest wounds and closed chest wounds. So open chest wounds, you guys, result from a penetrating object. This is your gunshots, your stabbings, impaled objects just in the thoracic area. An open chest wound can pull, like I said, it can pull air into the chest cavity, causing what we call a sucking chest wound. This is when you get on the scene, you might hear a sucking chest sound or bubbling sound in the chest area. We call that a sucking chest wound. Treatment for the sucking chest wound is normally when we would apply the occlusive dressing. But immediately, your first action should be cover the wound with your gloved hand and then apply an occlusive dressing and tape that on all three sides. And the reason why we tape the occlusive dressing on three sides, you guys, is because one reason is we want to prevent any additional outside air from entering the wound. That's why we cover it up. But the reason why we only tape it on three sides is we want to avoid trapping any air that is already in the chest. So we want to be able to allow that air to escape. And normally when you start seeing tracheal deviation, JVD, or your patient is just getting worse and worse, we will typically go ahead and burp the wound because that means that the air that is inside the chest is having a hard time escaping. So you just go ahead and burp it. Any questions about that open chest wound? All right, we'll move on. All right, so closed chest injuries, which can lead to a flail segment chest due to a blunt impact force that is strong enough to fracture two or more adjacent ribs, is what we would consider a flail segment. As you see in the first picture, that's encircling broken ribs along the right side of the patient's chest cavity. Um, the force can be strong enough to injure not only the lungs, but the heart and great vessels, along with the diaphragm as well. Uh, this is the time when you see patients inhaling and exhaling that you would notice one side of the chest moving upward and the other one is moving downward, like they're moving in opposite directions. We call that paradoxical movement. In other words, pretty much the side that is moving opposite, like when you're inhaling, your chest expands. That flail segment side, or the side that does have the broken ribs, is going to move downward, and vice versa. When you're exhaling, it moves upward, while your normal side of the chest is moving downward. Um, Flow segments are considered another emergency because it prevents the chest from generating a normal negative pressure necessary for inhalation. So that affected side doesn't create that negative pressure. So the outside air that we are breathing in is never going to fill up that lung with oxygen, and we're never going to release any carbon dioxide in that area. So pretty much no gas exchange is occurring, and it can lead the patient to hypoxia. Treatment for you guys when it comes to a flex segment chest will just be if patient is inadequate breathing, inadequate respirations in general, positive pressure ventilation. This is, your BVM with some high flow oxygen. Um, I know some people in the past have asked, well, what about just patient on the affected side on the stretcher and stuff like that? It is now considered to be contraindicated to place the patient on the affected side because splinting the chest can compromise other chest wall motion and just lead to more of the lung collapsing. Which is pulmonary contusion. All right, so this is your pulmonary meaning lung contusion. Is like a bruise, pretty much. So this thing, the lung is bruised. Lung is also another vascular organ. Um, so there's pretty much bleeding within the lung tissue around the alveoli. Remember, so these are your alveolus right here, and there's blood all around it, right? So what this blood is going to do is going to this gap right here between this capillary and this alveolus or alveoli sac is going to further spread them apart, making it difficult for them to do proper gas exchange. So your alveolus are not going to drop off the oxygenated air that it received from the outside, and the capillaries aren't going to drop off the CO2 that it's trying to waste from the body. So this also puts your patient at a risk of hypoxia. Um, so in this case, anyone who has suffered a significant blunt force to the chest should be suspected of pulmonary contusion. This could be that patient in a car accident that went up and over, right, hitting their chest on the steering wheel, stuff like that, or being hit in the chest with a bat, or um, any other thing that is significant, being blown to the wall from blast injury. If the patient is alert and um, able to maintain their own airway, supplemental oxygen is a okay route to go with. Um, if the saturation starts to drop, you might want to look at CPAP, and the patient is just completely unstable, inadequate respirations, positive pressure ventilation, and immediate transportation to the hospital is what you guys will want to do for this patient. So just remember, pulmonary contusion is the bleeding on the lung. The lung was injured by some um, outside blunt impact, causing blood to build up in between the capillaries and the alveolus or alveoli sac in the lungs, causing an increased distance between the two and making it difficult for gas exchange to occur. So your patient won't be perfusing adequately. All right. So an open pneumothorax, pneumo meaning lungs, you guys. Thorax is pretty much chest cavity. So an open pneumothorax is a result of an open wound to the chest created by a penetrating object. Air can be heard escaping or entering through the chest wound, creating bubbling or sucking sound. Uh, this is just like I said earlier. This is something that you're going to do the immediate direct pressure with your glove hand. Go ahead and apply an occlusive dressing and tape it on all three sides. Um, Open pneumothorax, keep in mind, can always lead to a tension pneumothorax if not treated immediately. And as you listen to lung sounds, you're going to hear absent lung sounds on the affected lung that has collapsed. Patient's going to have an immediate shortness of breath, difficulty breathing. Um, you might see a decrease in patient saturation. If they are unstable, not alert, inadequate respiratory rate, you want to go ahead, like I said, take immediate direct pressure of that open wound, dress it with an occlusive dressing on all three sides, and you want to start positive pressure ventilation, start bagging this patient with some high flow oxygen, and transport them to a trauma center immediately, or whatever is your nearest hospital, because their airway is in danger. And like I said, can lead to a tension pneumothorax. Pretty much the difference between an open pneumothorax and a tension pneumothorax is as that pressure is building up, as that air is leaking into the chest cavity. So all this air on the outside is just going to go into the chest cavity and cause a greater pressure, pushing everything and this area more towards the unaffected area. This is when you start to see that tracheal deviation, because all of this on the left-hand side of the patient is now being compressed. So with the heart being compressed and all of that, you're going to see a decrease in cardiac output, uh, more difficulty breathing, probably just completely unresponsive breathing, very hard, labored, um, decrease in patient saturations. They're going to slowly just be circling in the drains of shock. Absent breath sounds on one side again, along with like I said, along with the shifting of the affected area, just shifting more towards the unaffected area. When you start to see this, this is a late sign of like a tension pneumothorax. The best thing we can do is go ahead and burp our dressing and continue to bag the patient and get them to the hospital immediately. All right, so hemothorax, you guys. Hemo meaning blood, thorax is blood, the chest cavity. So there's blood in the chest cavity. This can be due to another blunt force that has caused bleeding, like your pulmonary contusion, or this can be from a penetrating object, like a stabbing gunshot, into the chest cavity, causing bleeding within the lung. One symptom or sign that you would see this patient, if they are coughing, you might see what we call pink frothy sputum, you know, coming out of their airway, going, into the environment. This patient you want to treat for shock and you want to manage it like you would with a pneumothorax. So if you need to bag the patient, go ahead and bag them with some high flow oxygen and immediately get them to the hospital. All right. Traumatic aphasia, you guys. Normally, there's an outside force that was great enough to compress the organs. So an outside force was strong enough to compress these organs and cause a backflow of blood out of the right atrium into the veins of the head, shoulders, and upper chest. So with this patient, they're going to just look um, extremely pale, like the face might look red. You're going to see jugular vein distension, bloodshot eyes that are protruding from the socket. They can have a bluish tongue that is swollen, and patient overall just appears like they were strangled. Um, and can just cause severe lung damage. Care for this patient would be to, if there is any wounds, go ahead and address those wounds and treat the patient for shock. All right. So before we move over into the next chapter, just want to talk about just rib injury. Let's say you did get into a car accident and you hit your rib cage on the steering wheel, or the airbag impacted you and just caused you to have like tender rib sensation. A lot of people, when they do have just ribs injuries, there's going to be excruciating pain, especially with movement and breathing. So this patient might have what we call shallow breathing, and rapid breathing. They can still be awake and alert, but they're just not breathing adequately. Um, Go ahead and just place them on like some high flow oxygen if they are awake and alert via non-rebreather, 15 liters per minute. Because the reason why they're breathing so shallow is because if they try to take a full deep breath, the injured ribs is just causing excruciating pain to where they don't want to keep feeling that sensation of pain, so they're just going to shallow breathe because it feels better for them. Keep them in a position of comfort and just transport them to the hospital. All right. All right, so abdominal and GU. See, I think we go over the anatomy first. All right, so important to remember your organs that are within the abdominal area. You know, remember what's in your right upper, right lower, left upper, left lower quadrants. Um, the difference between hollow organs and solid organs is important to know. Uh, Remember your hollow organs, which is your stomach, gallbladder, urinary bladder, uterus, internal urethra, fallopian tube, small intestines, and large intestines. The difference between them and your solid organs are that your hollow organs are not as vascular. However, they do contain substance that can be very, I'm going to just say, toxic to the outside body. So if these organs burst and get into your abdominal cavity area, it's going to lead to what we call peritonitis. This is a medical emergency. Can pretty much cause a patient to go into a shock and stuff like that. You want to get them to the hospital immediately. It can cause inflammation, irritation, infection of the peritoneal lining. Patient may or may not have any pain with peritonitis, but just keep in mind this is probably another time when you're going to see like gastric distension. It's hard and rigid, stuff like that. If they tell you that they been hit in the stomach with a baseball bat or something like that, a traumatic car accident, you want to um, suspect that one of these organs either is bleeding from your solid organs or one of the hollow organs has ruptured and is leaking substance into the abdominal cavity. Your solid organs, which is your liver, your spleen, your pancreas, and your kidneys, are very vascular. So these organs, if injured, lacerated, or anything like that, torn, will cause severe bleeding and can possibly lead to shock. Um, these patients might typically complain of shoulder pain, which is what we call the curve sign. Blood doesn't normally irritate the peritoneal lining, but it may irritate the diaphragm and cause pain to the shoulder. You need to keep in mind that if the abdominal aorta and inferior vena cava can be affected from abdominal trauma, and if lacerated, patient will fall into shock immediately, um, which you can see from a blunt or penetrating trauma. And just to go back over it, your abdominal cavity has two layers of membranes. This is also where you have your visceral peritoneal. Remember, your visceral peritoneal lines over the organs directly, so that it will lie over the liver, the spleen, pancreas, kidneys, and then you have your parietal peritoneal, which lines just pretty much over the uh, abdominal cavity area, that's not over the stomach. So it's parietal peritoneal, and then there's probably like a little fluid in between, and then your visceral peritoneal lies directly over the organ. And remember, your kidneys is considered to be retroperitoneal. They are behind the stomachs, uh, and all of that stuff. But just remember what's in your left, right, um, upper and lower quadrants, and that your solid organs are more vascular, at risk of bleeding out compared to your hollow organs, which they're not as vascular, but if ruptured, can cause substance that's toxic to the peritoneal cavity and cause peritonitis. All right. So in the pictures you see, as you can see, you have a man whose intestines is sticking outside of his abdomen area, right? We call that abdominal evisceration. This is when organs within the abdominal cavity has protruded outward into the outside environment. This could be caused to a significant penetration force, like a knife wound, GSW, something. Typically, your small intestines will be the ones that have eviscerated outside the abdominal cavity, and sometimes it could be small and large. The number one thing you do not want to do is you do not want to try to stick these organs back inside the abdominal cavity. For us, if this is seen or if this is something we see on scene, you want to go ahead and apply uh, sterile soak dressings that have been soaked in saline or sterile water around the organs, and then you want to go ahead and put an occlusive dressing around the cavity, abdominal cavity area to keep those organs from being exposed to the outside environment, because that is those organs are still what we consider sterile, and outside environment has a lot of bacteria and stuff like that in the air. So you want to make sure you don't expose that and increase the risk of infections. Just like in the book, it says, we don't want to cover these organs with aluminum foil. Reason for that is, aluminum foil is a good heat conductor. If they are outside, we cover it with aluminum foil. Might start making some boudin or something. So just keep in mind, you want to just put wet, sterile gauze or soaked in saline around the organs themselves, and then over on top of that, go ahead and apply some type of occlusive um, dressing to keep it contained and keep those organs moist and not exposed to the outside environment. If you got a big old Ziploc bag or something like that, go ahead, cut it up, and place it over the organs and tape it. And just treat this patient. They're awake and alert, put them on 15 liters non-rebreather. If they're unstable, inadequate respirations, you're going to go ahead and bag and transport them to the hospital. All right, male and female genital trauma, genital trauma. That's the male's penis is very vascular, you guys. If there is trauma to it, it will bleed excessively. If the patient is stable, you can go ahead and try to maybe ask them to hold direct pressure uh, until bleeding has stopped. If not, you will be the one trying to control that bleed until you get to the hospital. If it has been amputated, go ahead and wrap that in gauze uh, and place it over ice. Don't ever place it directly into a bucket of ice or into water. Always want to make sure you have it wrapped. If it's just like swollen testicles and stuff like that, you can give the patient a cold compress, a cold ice pack, have them hold the ice pack to the area to keep the swelling down. Um, to say the females, injuries such as sexual assaults, blunt trauma, abortion attempts, lax from childbirth, you want to go ahead and try to control the bleed. Remember, we don't stick anything into the vagina, so you just pad the outside area. Um, and if it just gets saturated, we just put dressing on top of it and get them transported to the hospital immediately. Let's see. All right, I think this is the last chapter. Multi-systems trauma and trauma in special patient population. Remember, patients with multiple injuries or multiple systems injury in the same area. A stab wound, just think of a stab wound to the chest, because it's not only affecting the outside skin or the three different layers of the skin, but it's at risk of affecting the cardiovascular area and the pulmonary area, depending on how deep that knife has gone. Same thing with a gunshot. Um, you don't want to get distracted by gruesome injury. So if you come on scene and you do have a patient whose whose intestines is sticking out, but the patient does have an inadequate breathing, you want to go ahead and control your airway, breathing, and circulation first, and then handle um, the eviscerated organs. Uh, Same thing with if you see that they're pinky toe is amputated, that pinky toe does not have priority over airway, breathing, and circulation. You want to go ahead and make sure your airway and breathing is stable, and then move on down to your other and control the bleeding from the amputated toe. So in one picture, they're showing the pediatric patient that they packaged onto a spine board, has them, all of that. Remember the pediatric appearance triangle. You know, you want to look at how the patient is looking, look at the work of breathing, and look at their skin for circulation. If it just seems like they're pale, not really moving around, you notice that they're breathing really hard in labor, or they're barely breathing at all, and they look gray or just really pale or cyanotic, that pediatric patient needs immediate attention. Um, Pediatric patients can compensate for a long period of time, but they do crash quickly. Like when they start spiraling down, they drop immediately. So you definitely want to always pay attention to a pediatric's ABCs. Even if they appear normal when you first get to them, you just want to keep reassessing this patient every 5 minutes, especially when they are involved in a significant trauma uh, impact, like from a really bad motor vehicle accident or a fall. Just always reassess because they start to decompensate very quickly. When it comes to a pediatric patient, remember that they, especially infants and young children, typically have larger heads than bodies. So when you do package them, you might want to put pads on the voids of the spinal area. Um, when you are immobilizing them to a spinal board or something. Geriatric is pretty much the same way. They typically don't compensate as well as you get older. You know, it's harder for the body to keep up, especially if trauma has been involved. So they also start spiraling down the drain very quickly. So you always want to keep that in mind as well. And that is it for modules 9 review. Anybody has any questions before we end the meeting? If you want to unmute yourselves, you can go ahead and do that, ask a question, or you can type it into the chat box. All right. So if there is no questions, I will be uploading this recording onto module 9. It seems that we can't really get the WebEx to save underneath these recordings in the WebEx section. So if you want to just go back over this later on before you take your exam, it will be posted in module 9. Okay. But everybody have a good day and good luck with your exam. Go ahead.